A very good morning to all. I think we better start this session because from the previous session, running late. So I just want to introduce this session. It's basically very much on the AVF setting now. We've had a lot of Sirolimus technologies for the lower limb, and this session is sponsored by Concept Medical. So on the panel, my name is Jun Tang. I'm one of the vascular surgeons from Singapore. On the panel, I have quite a distinguished people who have actually been running the forefront trials for this. I have Edward Choke, also one of my good friends from Singapore. Giresh Reddy, who's an interventional nephrologist from India. Dr. Tan, who will be phoning in from Singapore, and Sanjay Mishra from Rochester, Minnesota. Guys, can you hear me? I'm trying to coordinate.
Yep.
Hi, Milo. Hi. Dr. Reddy, can you hear me?
Yeah.
Good. Dr. Mishra, let's go. Okay.
Yes, we can. Thank you.
Okay, so I think what we'll do first up is that we'll go straight to the first talk, which is actually pre-recorded from Alok Finn, looking at the basic science of Sirolimus.
Hi, I'm Alok Finn from CB Path. I'm going to talk to you about the advantage of Sirolimus over Paclitaxel for treatment of AV fistula and AV grafts, a deep dive into the Sirolimus-coated balloon. Here are my disclosures. So, as introduction, following observation of traumatic arterial venous fistulas created by mechanical injuries, Brachiocephalic and Hurwitz first described the creation of the radiocephalic AV fistula forearm by side-to-side anastomosis in 1966. But despite this, really, we've got more problems with AV fistulas. There are high primary failure rates, and it's believed that ongoing needle proliferation with AV fistulas and AV grafts due to non-physiologic flow dynamics. And so we really need something to treat this high rate of graft failure. You can see here the cost of treating patients with failure of HD access grafts is huge. Multiple percutaneous techniques and tools have been used to treat these. But at best, the secondary patency of arteriovenous grafts is 50% at 3 years, certainly not acceptable. Paclitaxel coated balloons have become an important aspect or new treatment for stenotic AV graft stenosis. You can see here this was the Admiral by Medtronic, as well as Lutonix balloons are both approved for AV graft stenosis. Now, how does this work? Of course, the problems with this are the retention of surface paclitaxel crystals in the deposited area in terms of the balloon. The coating integrity of these is very variable, and you can see there's significant loss of paclitaxel into the downstream tissue beds as well as the bloodstream. It's a very inefficient way to transfer drug to the arterial wall. So that's why we need a Sirolimus coated balloon. Certainly Sirolimus is the standard for coronary disease via DES. Doesn't have to have this crystalline modification, which means loss of that to downstream tissues. And obviously, there are still significant safety concerns regarding the meta-analysis by Katsanos. And these are all examples here I've shown you. Now, paclitaxel safety concerns persist. You can see the FDA, despite the SWEDE analysis published in New England Journal looking at paclitaxel balloons versus control, you can see that the FDA still says newer paclitaxel data are comforting but limited. And there's significant losses, I mentioned before, paclitaxel into downstream tissues and blood. And the dose of paclitaxel is not insignificant on some of these balloons, as shown in the table. So why does Sirolimus offer benefits? Well, I'm not going to go over all the details, but certainly it's got a wider therapeutic index and safety margin, although it has disadvantages of slow tissue absorption and retention versus paclitaxel. And really, in order to make this work, we've got to enhance tissue absorption and extend tissue retention. Now, the nanolute technology by Concept Medical, which is in the Magic Touch, really encapsulates the Sirolimus into phospholipid particles. And these particles are transferred to the arterial wall where they basically mimic body lipids and liberate Sirolimus over time. Here is a schematic illustrating submicron particles, phospholipid carrier, and then they're combined and sprayed onto the balloon directly. Now you can see does work in terms of pharmacokinetic levels are shown over time, and there are detectable levels at least after 60 days. So we do have effective drug transfer. The AV fistula model is well known. In animal models, we combine we basically create a fistula between the femoral artery, iliac artery, and the femoral artery. And we can use histologic markers, as I mentioned here, to indicate safety and efficacy, including endothelial cell loss, fibrin deposition, medial muscle cell loss. All these indicate histologic efficacy in terms of drug effect. And we can also do downstream sampling in tissue beds in the animal models to look at whether their downstream emboli have occurred. And you can see here's an example of Paclitaxel DCB in the swine AV shunt model. And you can see we deploy the balloon in the vein here with the anastomosis. And you can see there is evidence of drug effect with fibrin deposition in the anastomotic site, indicating efficacy. Now at 60 days, this is the magic touch. You can see looks fairly good. You don't see any of toxicity or drug effect. And this study analysis is ongoing. I will not present the entire points to you. In conclusion, sirolimus is the preferred drug for intravascular interventions. Paclitaxel-coated balloons are limited by high rates of distal embolization into the body. These concerns were heightened by Katsanos and limit the safety of treatment of AV fistula and grafts with Paclitaxel-coated balloons. Magic Touch sirolimus-coated balloon demonstrates successful drug transfer of the arterial wall out to 60 days. An ISR study at 30 days in porcine model showed no evidence of toxicity. This is a promising new technology for treatment of AV fistulas. So with that, thank you so much for your attention.
Thank you, Dr. Fint, for presentation. We'll go straight to the next talk, which will be presented by Dr. Tang. Dr. Tang is one of the pioneers for the use of sirolimus-coated balloons for both peripheral arena and also for the AVFs and AVGs, and he will be giving us a talk on his Matilda trial 2-year follow-up presentation and also cases.
Thanks, Eddie. A very good morning to all. I've been asked to give this 2-year talk, basically, of Matilda. This was actually a pioneering study to look as a pilot study to get information to power and randomized controlled trial, which is happening now at Singapore General in Singapore. This study basically was to look at the 6 months and 12 months outcomes using the Magic Touch sirolimus-coated balloon for dysfunctional AVFs only. So these were the study endpoints that we previously presented at Link. So obviously we looked at safety, access circuit patency, both at 3 and 6 months, target lesion primary patency, and technical success. So just to give you an idea of what we do, this study consisted of 33 patients, purely at Singapore General. Now, this was enrollment nearly 3 years ago, the first patient came into. Singapore General does about 3,000 access and rescue procedures per year, so there's quite a high volume. It's the highest in Singapore. Our lesions are generally multiple and longer than in the West, and our stenting is generally not the preferred option in our patients. So these were the inclusion criteria, very liberal, but what we had to do was we have to pre-dilate the lesion with a high-pressure, non-compliant balloon and face it completely with less than 30% residual stenosis before we had to enroll it into the DCB section. We allowed an extra lesion, but no more than that, and we kept the reference vessel diameters between 5 and 8 millimeters. So just turning to patient demographics, you can see that these patients have high comorbidities. About 65% of these patients were diabetic. And turning to procedural data, if you look at it, it's 33 subjects with 47 lesions. About 40% were in the juxta-anastomotic section, within 5 centimeters from the juxta-anastomosis, and the rest comprised of non-JAST lesions. And the majority for these interventions were dropping access flow from the dialysis centers. In terms of treatment outcomes, you expect 100% technical success rate and 100% freedom from device or procedure-related mortality. Turning to the patency outcomes, at 6 months, just to remind you, we had pretty decent target lesion primary patency of about 83% and a circuit access patency of around 68%. The 12-month data, albeit they dropped, which is typical of what you typically find, whether you do DCB or not, but dropped down to 58% for target lesion primary patency and a circuit access patency of about 45%. So this is the new slide of interest for this talk. You can see it drops further. From 12 months, you got target lesion primary patency about 35% and down to circuit access patency of 15%. In terms of safety, no further deaths at all, and no complications such as bronchopneumonia or pulmonary embolism is what people actually are looking at for AVFs. This is an example of one of the cases, early cases that we enrolled, a complex lesion, a Malay gentleman in his 70s with a right radiocephalic fistula, and you can see he's got 2 annular segments already. There was a juxta-anastomotic lesion as well as a lesion that crossed the elbow. And over time, we ballooned this up, and you can see we follow them up. You can see these flow rates at 6 and 12 months. And actually, you hadn't re-intervened until approximately about 15 months, where he had another lesion in his central vein for right arm swelling. And we did the angiogram for the AVF, and actually wasn't too bad, except there was some restenosis around the outflow vein, which wasn't touched at the time. He came back in again with high venous pressure and a re-occlusion of his stent in the central vein, and this time there was some restenosis, which we ballooned up, and this was just Pobard. And that's what it showed. So a lot of these patients represent not with their main lesion, but actually with their circuit, and with the rest of the circuit having issues. We've also done work with another Sirolimus balloon, but if you look at the data, very similar between the two. This was presented at Charing Cross, and you can see the data is very similar. There's a drop in flow, typically between 6 and 12 months, and the question is whether we should be reloading these AVFs with drug. And you can see very similar target lesion primary patency and circuit access patency. So in conclusion, ladies and gentlemen, the Matilda study using the Concept Medical Sirolimus-coated balloon showed excellent technical and clinical success rate. It looks safe. It's not really associated with any serious adverse events. There's a safety signal there. In terms of efficacy, we can talk about this in the discussion. Too early to say. I don't think you can compare yet to the Paclitaxel balloons. We do need longer data, longer-term data, and randomized controlled studies are starting to go. I think in terms of where we treat these AVS with drug, I think we need to think very carefully what type of lesions we do have and where they are in the circuit, and another point for discussion too. And maybe some of these lesions will be more typical to be treated with drug and better treated with drug than without. And at the moment, I think there's one trial that's going on at SGH, read by Dr. Tan, and there's another one that is going on as well at SGH using a different balloon. And we'll hear from that very soon. And that, thank you very much for your attention.
Thank you very much, Chun. So you've given us a really nice presentation on the 6 months, 12 months, and now the 24 months outcomes. Can I ask if you could summarize for us, how do the Sirolimus-coated balloons performance compare with the Paclitaxel-coated balloons? We've got a lot of data coming out in the last 10 to 15 years, and most of these are level 1 evidence from the Paclitaxel-coated balloons. So how does Sirolimus-coated balloons compare with the data from the Paclitaxel arena?
That's a great question, Eddie. And in fact, this question was asked to me when I was giving a talk at Charing Cross. And I think at the moment to say is all the data is really from Paclitaxel. And I think you're going to be comparing apples and oranges at this stage with the two devices. There's been a couple of hundred of these patients in follow-up, prospective follow-up for using Sirolimus. We've got thousands of patients with Paclitaxel. Now, everyone looks at the impact data from using the Medtronic balloon, and they get some fantastic results. But you've got to say, in any randomized control study, is that the data is very sanitized, in terms of you've got very strict inclusion and exclusion criteria. What we did with these other smallest pilot studies from SGH was to generate pilot data so that we can actually power calculation to do a randomized controlled study. And this reflects everyday practice in Singapore with very tough lesions and all comers. So I think at the moment it's very hard to say. It is promising. The safety signals there, and Sirolimus, we know from the basic science, do have advantages over Paclitaxel, especially the anti-inflammatory effects. So I'm looking forward to the RCT data and a lot more patients enrolled.
And also, I'm very interested in knowing, and these questions can be extended to the rest of the panelists who are joining in virtually as well, please. So for AV access, the failure points can occur in many areas. For example, the juxta-anastomosis, the vein outflow, or the cannulation zones. Do you think I appreciate the numbers are still very small in this early data, but are there any differences in these different areas of the circuit that some may respond better and some may respond not as well to drug elution?
Why don't I take that question first, and then we'll open it up to the other panelists. When we looked at the subgroup analysis, although be it small as well because of the numbers, we did not see any difference in terms of whether it was in the juxtaanastomosis or not. I know there's been recent debate about the cephalic arch, and that the impact data showed some pretty favorable outcomes in the cephalic arch, but we didn't see that at all with this very small study, and I don't think you expect to. It'd be very nice to hear from one of the panelists. Dr. Reddy, what's your experience from India? Because you've used quite a lot of these balloons.
The first thing is, so far the results from India have been very promising, in the sense that the 6 months and the 1 year patency has been pretty much identical to what you have presented. But one challenge or the gray area which we are about to see in these balloons is, none of these trials have mentioned about the timing of intervention. Because that is one gray area, because you don't know what is the outcome when you intervene at the lesion being detected at 1 month, or when the lesion has been intervened after detection after 2 months. I think that also matters, because at the end of the day, the amount of fibrosis and the amount of calcification, all those matters in terms of the outcomes of patency. So unless we address that, or we have an uniformity regarding the timing of intervention, it is difficult to comment. But as of now, our data remains very much identical to what you have presented.
Thank you very much. Why don't we continue the debate in a while? Let me go to the next talk. I would like to present Dr. Tan, who's one of my interventional nephrology colleagues from SGH, and he led a study using this balloon in the graft vein junction in blocked AVFs. Dr. Tan, can you hear me? I think you're enjoying yourself on the cruise at the moment, are you?
Many thanks for the invitation to share the 2-year outcome of the salvage of thrombosed AVG with Sirolimus coated balloon. These are my disclosure. I receive research and education grants from the following companies. To start off, this is a brief recap of the study that was conducted a few years ago. It was a single-center prospective pilot study in 20 patients who presented with thrombosed AVG. Sirolimus coated balloon was applied at the graft vein junction following successful endovascular salvage of the AVG. The patients were followed up for 1 year, and the primary endpoint of the study was the primary patency rate of the AVG at 3 months, while the secondary endpoints were the primary and secondary primary patency rate of the AVG at 6 months and 12 months. Details of the study protocol could be found in CBIR Endovascular, published in 2020. Details of the study population is as follows. 37 patients were screened and 20 patients were recruited. Although 20 patients were recruited, only 17 patients completed 6-month follow-up, as there was 1 death and 2 surgical interventions as shown in this flow chart. The results were published in JVIR in 2020, where we reported a 3-month and 6-month primary patency of 76% and 65% respectively. This is how the Kaplan-Meier curve looks like, with a mean estimated primary circuit patency of 285 days post-treatment. Only 15 patients reached 12 months follow-up, as there were 2 additional deaths. The primary patency rate at 12 months was 40%. Our 12-month study results were accepted by the Journal of Vascular Access, and it should be available for viewing soon. When we compared our patency rate with other studies that were published in the literature on the use of cutting balloon and stent graft in the salvage of thrombosed AVG, you can see that in these 2 large randomized controlled trials, comprising of more than 100 patients each, the 6-month circuit patency was 37.5% with the use of cutting balloon, and 34.2% with a stent graft. The plain balloon angioplasty, which acted as the control group, was the worst, at between 21 to 29% patency rate at 6 months. In our study, which is very small and hence vulnerable to selection bias, nevertheless, the 6 months and 12 month circuit patencies were 65% and 40% respectively. Larger head-to-head randomized controlled trials are necessary to verify our findings. So what happened beyond 12 months? Many of our patients in Singapore are on hemodialysis as their destination therapy due to our very low transplant rate and will require a functioning access to continue their dialysis treatment. This is the result of 24 months. There are only 10 patients who completed 24 months of follow-up. There were a total of 6 deaths, which reflected the high mortality burden in our dialysis cohort. 2 AVG were abandoned due to recurrent thrombosis within the 2 years, and 2 surgical revision, which was previously mentioned. The primary unassisted patency at 24 months was 10%. Only 1 patient's AVG remained patent at 24 months, and she was very fortunate to receive a kidney transplant. The median patency post-Sirolimus in this 10 patients was 304 days, with a range between 134 to 676 days. This is a summary of the 10 patients. The x-axis represents the number of months, and the y-axis represents each patient. The blue bars represent the number of months that the AVG remained patent after treatment with Sirolimus coated balloon, while the rest of the colors represents the patency after each subsequent intervention. You can see that 4 patients managed to cross the 12 months mark quite comfortably, and multiple interventions averaging 1 to 2 interventions and up to 6 interventions within 12 months after the index procedure were needed. In conclusion, due to the high rate of mortality in end-stage renal disease patients and high frequency of AVG complication, long-term intervention studies are difficult and lacking. The effect of Sirolimus coated balloon angioplasty appears to wane with time. This is probably due to the fact that the stimulus for neointimal hyperplasia is not completely removed, and the effect of a one-time application of Sirolimus is likely to wear off with time. Hence, raising the question whether repeated application of Sirolimus coated balloon will be beneficial in reducing the number of interventions required each year to maintain the patency of the AVG. With that, I thank you once again for your attention. I'll be happy to answer any question later.
Dr. Tan, thank you very much. Can we just hold your questions for the time being? Actually, we have Alok Finn actually on the aeroplane itself, so I know he's about to take off. So we'd like to address some questions to him. Alok, can you hear us?
Nice to see you all. Yeah, can you hear me?
Yes, I've not done this before, but we can hear you. We've got a few questions for you to try and tie in the basic science of use of Sirolimus in AVF. Do you think the use of Sirolimus in the AVF setting, what other challenges do you think from a mechanistic point of view, as opposed to the lower limb where we've been looking at it quite a lot? Where do you think the challenges lie there?
I think there are multiple challenges. I think getting the drug to transfer properly and stay for long periods of time is going to be a challenge, simply because it's a high flow circuit. And that's not the same as other circuits. The other issue, of course, is ongoing shear, which is a stimulus for continued intimal hyperplasia. That means drug levels really have to be sustained for long periods of time. I wasn't here for all of Jack's presentation, but it sounds like to me there was some success with the Sirolimus coated balloon, but it wasn't, black and white.
Do you think we need reloading of drug into the wall of the AVF at some point? Because these new Sirolimus balloons have like a controlled release. They got long-term release, but ultimately you want a drug that is going to release even longer. Do you think those are the what advantages we need?
Yes, that is an advantage. And one of the problems with this area is that preclinically, we have a very limited model. You can do the AV fistula model in the pig, but you can't carry it out long term. So the PK data that is used for this type of model comes from the peripheral model. It doesn't come from the AV fistula model. So we really don't know the amount of time the drug stays in the wall after you apply it in this particular model. That's one limitation in terms of how much the preclinical data can predict success.
Could you just quickly let the audience know, I think you're the best person to probably explain it, this balloon, the Magic Touch balloon, how is the mechanism tied in to release of Sirolimus into the drug, into the adventitial area?
Okay, so there's a phospholipid carrier that basically is encapsulating the drug with a hydrophilic and a hydrophobic tail. that carrier, that phospholipid carrier, almost like a cell membrane carrier, is transferred to the arterial wall, where it sticks and stays over time, and the sirolimus is released over time within that carrier. And so that's really the mechanism this particular product uses to sustain sirolimus levels over time. I would say the phospholipid carrier is fairly harmless. It doesn't cause a lot of toxicity, and there's no evidence that we've seen in our study, preclinical studies, of arterial toxicity at all. So I think the product is safe, and the effectiveness is going to have to be shown in carefully controlled clinical trials in every area, from AV fistula to SFA to BTK to coronary.
One last question to you. The drug concentration on this balloon is about 1.25 mics per millimeter squared, and the other one is about 1 millimeter per millimeter squared. Do you think we need more drug? Because all the big studies have basically shown that with those high dose balloons like the Impact, that the higher dose seems to have a better effect. Do you think it's the same for sirolimus?
I think the dose of the drug is not as important as the sustained release of the drug over time. And that's the trick with sirolimus. If you just transferred sirolimus on a balloon and blew it up in the arterial wall, there'd be no sustained release. It would basically be gone within a matter of a day. So the carriers are absolutely essential to house the drug to allow it to release over time. And it's the combination of the drug with the carrier that really allows it to have that sustained release. And that's what we have to focus on, are those carriers, making those carriers as effective as possible without causing toxicity.
Thanks, Alok. And have a safe flight back.
Thank you. Thank you so much.
Speak to you soon. Should we go on to the next talk? Yeah, I think so. So the next talk, I think, Dr. Tan, I'm sorry for interrupting you. I think you want to give the next talk on update on the impression randomized controlled trial using this balloon against POBA. Thank you.
Many thanks for the invitation to give an update on the impression trial, which stands for sirolimus coated balloon angioplasty versus plain balloon angioplasty in the treatment of dialysis access dysfunction. These are my disclosure. I receive research and education grants from the following companies. Impression is an investigator-initiated trial to evaluate the effectiveness of sirolimus coated balloon, specifically in AVF. It is a prospective multi-center study conducted in Singapore. The primary outcome is the primary circuit patency at 6 months post-angioplasty. In particular, we are looking at the freedom from clinically driven indication for re-intervention or excess circuit thrombosis after intervention. For sample size calculation, we assumed a 6-month target patency of 73.7% for sirolimus coated balloon versus 55.2% with plain balloon angioplasty. After assuming a 10% dropout rate due to death, a sample size of 170 patients would have a power of 80 to detect a difference between two groups at 6 months with a p-value of less than 0.05. The patients were allocated in 1:1 ratio, either into the sirolimus coated balloon angioplasty group or the plain balloon angioplasty group. These are the inclusion criteria. Essentially, we are looking only at mature AVF, which is defined as an AVF that has been in use for at least 1 month prior to angioplasty. Consent is taken prior to procedure, and the last criteria, which is successful angioplasty of the underlying stenosis on DSA, can only be determined on table. Only patients who are able to achieve less than 30% residual stenosis in all the lesions present in the circuit will be randomized. Remember, we are looking at circuit patency as our primary endpoint. Hence, all lesions, if more than one, will need to be adequately treated with less than 30% residual stenosis prior to randomization. The patients are randomized using a secure web-based program developed by Singapore Clinical Research Institute, and only the study coordinators remained unblinded throughout the study. Both the patients, the study team, and the patient's own renal physician and vascular surgeon remained blinded throughout the entire study. The trial started recruitment on 1st January 2021. These are the co-site principal investigators, Professor Jackie Ho from National University Health System and Professor Edward Chok from Sengkang General Hospital. To date, we have recruited 101 out of the 170 patient target, and Singapore General Hospital has completed its recruitment target of 70 patients. This is the baseline demographic of the 70 patients recruited in Singapore General Hospital. The mean age is 65 years with a predominant male gender. The ethnicity of the cohort is a reflection of our multi-ethnic society, and the main cause of ESKD in our cohort was diabetes mellitus. Again, a reflection of diabetes as the main cause of kidney failure in Singapore. The AVF were rather old. The median time from AVF creation to recruitment was 45.8 months. Majority of the AVF were radiocephalic, which account for 60% of the cohort, followed by brachiocephalic fistula, and then brachiobasilic AVF. This AVF has multiple stenosis. Only 1/3 of them has a single lesion. Majority of the AVF has more than one stenosis. Approximately half of the patients receive repeat intervention post-index intervention. The median time to re-intervention is 5.1 months. Up to 63% of the brachiocephalic fistula require a repeat intervention, while approximately half of the patients with radiocephalic AVF required repeat intervention since enrollment. Here are the reasons for repeat intervention. Majority of it is due to failure to achieve adequate dialysis or thrombosis of the AVF. This is one of the patients that was recruited in March 2021. She has a left DVT AVF with juxta-anastomotic and swing zone stenosis. The swing zone stenosis was resistant to effacement at 20 atmosphere with a 7 mm by 4 cm Mustang balloon. As the trial required patients to have less than 30% residual stenosis before randomization, a 6 mm cutting balloon was deployed. The lesion was extremely resistant despite inflation to 10 atmosphere 3 times, as you can see in the following images, with a cutting balloon, and was finally fully effaced after repeat application of the 7 mm by 4 cm Mustang balloon after the application of the cutting balloon. This is the appearance of the swing zone after adequate treatment. A 7 mm by 6 cm trial balloon was then applied over the swing zone, and this is how it looks like on DSA after treatment with Sirolimus coated balloon. The juxta-anastomotic stenosis proved to be extremely resistant as well, and the same cutting balloon had to be used. You can see that the cutting balloon ruptured at 10 atmosphere with contrast extravasation, and the lesion remains stubbornly resistant. The resistant lesion was finally effaced at 24 atmosphere with a 6 mm by 4 cm Mustang balloon. And this is how the AVF looks like after intervention with a beautiful juxta-anastomotic and swing zone segment. The juxta-anastomotic stenosis was then treated with a 6 mm by 6 cm trial balloon, and this was the final appearance on DSA. The AVF remains patent for 8 months post-intervention, and this is how the AVF looks like in December 2021. We will remain blinded with regards to whether the patient received the placebo or Sirolimus coated balloon. For the second case example, this is the timeline of the AVF from the time of creation. The AVF was created in December 2019. It functioned well for 10 months before he received balloon angioplasty in October 2020 for low flow fistula. The access then thrombosed 3 months after angioplasty in January 2021. The thrombosed access was successfully salvaged with a thrombolysis and treatment with plain balloon angioplasty. He presented again 3 months later after successful thrombolysis with low flow in April 2021 and was recruited into our study. This is how the AVF looks like before treatment. As you can see here, there are multiple stenosis located at the juxta-anastomotic segment, the intercannulation site, and the cephalic arch. After recruitment into the study, his AVF remained free of intervention for 11 months. And he actually thanked me for recruiting him into the study, although I told him I do not know if he received the placebo or the sirolimus coated balloon. He himself was convinced that he received the sirolimus coated balloon, as it seems to last longer than his usual treatment. He presented again in March 2022, requiring intervention for inadequate dialysis, and the fistulogram showed recurrent stenosis, and he received treatment with POVA. However, 2 months later, his dialysis center contacted me to report that his AVF was pulsatile with a high venous pressure after treatment with POVA. Again, this patient remains convinced that he received sirolimus-coated balloon, and the history seems to suggest so, but we remain blinded till the trial is completed. In conclusion, Impression has completed more than 50% of its recruitment target. Some of the patient has completed at least 6-month follow-up. Majority of the recruited patient has a redocephalic fistula, and many of the stenosis in the AVF were multifocal in nature. We eagerly await the completion of the study, and I hope that we will be able to share the results of the study in a meeting next year. With that, I thank you for your attention, and I'll be happy to answer any question you have in the Q&A segment. Thank you.
Thank you very much, Dr. Tan, for giving us a really nice update on the Impression RCT. And I'm one of the sites who are recruiting for this trial, and so I may be a bit biased, but I think it's a very well-designed trial. So Dr. Tan, could you perhaps give us a summary of the key designs of the trial and how it is similar or different to the previous RCTs using Paclitaxel-coated balloons?
Thanks, Eddie. I think the main objective to a patient with a fistula problem is whether the intervention is going to last the patient. And it brings little comfort to the patient if we tell them that at 6 months, the target lesion patency is good, but the fistula requires a repeat servicing. And it is with this mindset that we wanted to recruit and treat all stenosis within the dialysis circuit. And as you can see in Singapore, majority of the patient, up to 2/3 of the patient, has more than one stenosis. And therefore, by adequately treating all the stenosis, we hope to prolong the time needed to the next intervention. And that was how the trial was being designed, to look at the primary circuit patency at 6 months. And to achieve that, we are treating all stenosis with sirolimus-coated balloon, and all stenosis has to be adequately treated, whether it is the target lesion 1, target lesion 2, or target lesion 3. Now, the second point was actually raised earlier by one of the panelists, is regards to the indication for intervention. In this aspect, we actually tied down what are the indications for intervention in the trial design. And secondly, we actually have ultrasound scan at 3, 6, and 12 months to actually look at the rate of restenosis after treatment. However, interventions are not based on the scan finding, but instead based on the clinical finding, which is what the KDIGO guideline and KDOKI has actually advocated in the recent update in their guidelines. So I think this trial is as close as we can get to the real world, while we are actually focusing on primary circuit patency at 6 months as the desired outcome for interventions. Of course, one can argue whether the de novo lesion will sink the boat. But we believe that if we can treat this stenosis adequately, this patient will benefit from a decreased number of interventions per year to maintain the circuit patency. And this will prove to be a cost-effective treatment in maintaining circuit patency, rather than just focusing primarily on target lesion patency.
Okay. Thank you. And I'm also very interested in the power calculation and the derivation of the sample size, because I note with interest that in the Matilda study, the 6 months target lesion primary patency was about 80%. And in your power calculation, you predicted it was based on a 73% primary patency at 6 months. Maybe this question will go to either yourself and also Professor Tang. So how do you see as the potential primary patency at 6 months? So you have quite a lot of leeway and in terms of the primary patency. Yeah.
Yeah. So I think in a small study, we are worried whether there's selection bias or whether there's and therefore we actually give a certain percentage reduction in when the data is actually applied to a larger cohort. And secondly, we also hypothesize that the Sirolimus is probably as good as, if not better than, the Paclitaxel coated balloon, and therefore we used the number of 70% as our sample size calculation as in doing the design of the study. I think what is also important is also the POBA arm. As you can see from the other randomized controlled study, many of the POBA arm actually do better than the real world because of the need to treat the lesion adequately. And therefore, when we took at all into consideration, we decided on the sample size calculation based on the figure of 70 versus 40%. That means a 20% improvement in the primary circuit patency at 6 months. We actually powered it to find a p-value of less than 0.05. In contrast to US FDA data, I think for IDE study, they actually detailed a 0.025% significance, and that will actually double the number of patients that is required. And secondly, of course, in terms of the trial design, we talk about one-sided versus two-sided. We think that it will be a superiority study. That means the outcome will be that whether Sirolimus is better than POBA based on our preliminary study, rather than whether POBA is actually better than Sirolimus. So I think that was how the sample size was actually derived and calculated in designing the study.
Thanks, Dr. Tan. I think for the sake of time, we need to move on to the next talk. This talk will be given by Dr. Reddy from India, and he's going to give us a complex case presentation using the Magic Touch balloon. Dr. Reddy, thank you.
Yeah. Just waiting for these slides. At the outset, I would like to thank Link for having me again for this wonderful session. This is pretty much close to my heart, this topic, because the restenosis in our AV access lesions is a main concern for our patients as well as the treating physicians. I have no disclosures. Okay. So, as my previous speaker has highlighted, what is the necessity for drug-coated balloons versus the conventional POBA? So far, drug-coated balloons are showing better results than the conventional POBA, whether it was IMPACT trial or the one which has been presented few minutes ago. Then the concern with Paclitaxel coated balloons, which are existing in the market, was of long-term systemic toxicities. And so far, the results have been promising with Sirolimus coated balloons in both coronary and peripheral vessels, with better results than the conventional Paclitaxel coated balloons. So, what is the rationale for DCB? As the speakers have highlighted, elastic recoil is very common problem resulting in recurrence of the lesion. So, in this video, you can see there is cephalic arch stenosis, very tight lesion presenting with high venous pressures. And then we have did a conventional POBA, and this is how the lesion appears. And again, after some time, if you see the same lesion, it has recurred again. So this is the issue we are trying to address with the drug-coated balloons. Next slide, please. Okay. So since Sirolimus initially had few technical challenges, the nano-lute technologies has been highlighted by Dr. Alok Finn. It has its own advantages. It facilitates better adhesion, effective drug transfer to the vessel wall, and circumferential coating, and also better tissue availability. Okay. So first case is a 59-year-old male on end-stage renal dialysis, end-stage renal population on hemodialysis. This is a common problem in India. Multiple vascular access failure, had non-tunnel catheters multiple times, and then he was on dialysis through left transposed brachiocephalic fistula, had high venous pressures and was convinced for fistulogram. Then the fistulogram was suggestive of swing segment stenosis. So we explained the endovascular procedure, and he opted for the drug-coated balloon. So we used drug-coated balloon, and post-procedure, he had good flows with reduced venous pressures. The hyperpulsatility of the outflow segment has decreased significantly. His URR, which is a primary concern, has improved very significantly. And in this patient, the early presentation and intervention was key, and he continues to use the same fistula. Then I'll go to the second case. She was a 50-year-old female with left brachiocephalic fistula. Again, she had a very high venous pressures during dialysis, also had low URRs, and the potassium was another significant problem in this patient because of recirculation. We did fistulogram and angioplasty. Here you can see there is a critical stenosis of the cephalic arch. You can see a tortuous outflow vein, and then normal central venous system. And this is the image post angioplasty with drug-coated balloon. Had a very good outcome, and this has been post 6 months. Patient continues to use the same fistula with good venous pressures, and her URR is very good. So hopefully in next meeting, I'll be able to present her 1.5 year data. The third case is end-stage renal disease due to allograft failure. This patient had swelling of left upper limb and face, and also had severe pain of the left breast, probably because of the engorged mammary vein. And then we counseled her for endovascular procedure, and anticipating the central vein lesion, I have counseled her for the drug-coated balloon. So this is the primary fistulogram image showing critical stenosis of the left brachiocephalic vein, where it joins the superior vena cava. Then, as the usual procedure, conventional probe with ultra high pressure balloon was done. Once the lesion was adequately pre-dilated, then we used a drug-coated balloon. And finally, there is a restoration of flow. Her symptoms have improved. Breast congestion has decreased, and then she has a good URR so far. And the PTCA patency period after 3 months has been excellent. This procedure was done in January, and so far everything is good. So again, in this case, early diagnosis and management is key. So what are the conditions where DCB might be effective? Lesions with evidence for aggressive neointimal hypertrophy, rapidly recurring lesions, instant or stent-edge lesions, then central venous lesions, because the challenge is to decide on stent. If you stent on one side, you're jailing the other side. So in this area, I think a randomized control trial can also be done. And this is one area where you absolutely want to use drug-coated balloons. So to conclude, DCB is a novel treatment for managing access failure. Magic Touch AVF Sirolimus coated balloon is safe and helps in decreasing the risk of restenosis. And so far, Indian results have been very promising. I'm looking forward for a large randomized control trial because my patient population is a little different. Thank you once again for the opportunity.
Thank you very much, Dr. Reddy. A quick question to you, and I'm sure the crowd will want to know. What is your protocol of using DCB in the AVF setting? Do you use it routinely for every lesion, or do you use it only for early recurrence? And how do you prep the lesion routinely as well before you put the DCB in?
All right. First of all, I want to be very honest. In India, economics play a huge role. So the first thing is, regarding, I also explain to the patients about the cost of the balloon and ensure they're adequately affordable. The second thing is, as routinely done for any other drug-coated balloon, I adequately dilate the lesion with ultra-high pressure balloon. So our lesions conventionally respond at around burst pressures of around 25 to 30, some of the lesions. And then once I have done adequate dilatation, then I use these drug-coated balloons. And when I'm anticipating aggressive intimal hyperplasia and restenosis, for example, on table, if I see a severe elastic recoil of a lesion, then I'll go for this drug-coated balloon. The second thing is always I prefer to use drug-coated balloons in central venous lesions. Say, for example, I have in this case, last case I presented, if there is a lesion of left innominate vein, then if I stent straight away, I have to sacrifice the right side. So I prefer a drug-coated balloon in this case. And also, if the recurrence of the lesion is within 3 months, I prefer a drug-coated balloon.
Thanks very much. Just one last thing about how long do you keep the balloon up for the drug? Just quickly.
I use 3
long?
months. 3 minutes.
3 minutes. Thank you very much. Is that everybody on the panel? Dr. Mishra, I haven't heard very much from you. Sorry about that. How long do you keep up a drug-coated balloon for in the AVF?
So depending on we only have Paclitaxel, so we have BARD or the impact. 2 to 3 minutes is how long we would keep it up in our practice.
Sure.
I'll just make some comments.
Sure.
One, thank you for the invitation. It appears to me from a U.S. standpoint that the phenotype of the injury that we're seeing in Singapore may be different than what we see in the U.S. And the severity of the lesions. And maybe we could comment on that. I think this world experience is really beneficial to all of us. Then the other comment I'll make is my lab uses the pig model that Alok Finn described, actually, and I think we can do pharmacokinetic assessment for Sirolimus in the vessel wall using mass spec, if that's an interest. So there's a couple points I'll make. We've had that model. We've done extensive work using animal work, and so we could link the biology to the human biology. I obviously treat patients with this disease, and so maybe we could talk a little bit about that. Where would the limuses do better? Is it the anastomosis or the arch, for example? I would love to hear what others think, or Paclitaxel technologies. So a few questions.
If I'm allowed to ask one question, I have a question for my Singapore colleagues. The first thing is, my question was whether we can consider coating the Sirolimus to the ultra-high pressure balloons itself, so that in one shot, we are dilating the lesion as well as releasing the drug. That way, we are avoiding the use of 2 balloons or 3 balloons, because so far as my knowledge goes, initially we have to prepare the lesion by using ultra high pressure balloon, prepping the vessel, and then we are using this drug coated balloon. So my thought process was whether coating the ultra high pressure balloon itself with this drug helps our cause.
I think that's probably not a good idea, because you have to prep the lesion first to get the drug to the wall. By leaving the stenosis first, you probably would actually wash a lot of that drug off the wall passing through the stenosis. So probably not a good idea. I think that's one concept, one point. Can I just quickly ask Dr. Mishra, because I know you do a lot of basic science along with Alok, what do you think about loading the wall regularly with drug? Because we're seeing the effect, typically with both Paclitaxel and Sirolimus, you get the decline typically between 6 and 12 months. Now, not all of that is related to recoil. Some of that is also related to the neo-intimal hyperplasia effect. What do you think about regularly loading the wall with drug?
Yeah, I think that's an interesting concept. I think the questions are, one, around pharmacokinetics and how long do you need the drug? And so I think what you pose, treating with DCB at your index lesion and then coming back maybe periadventitially would be a way to go, and then delivering drug. Now we've done periadventitial targeting experimentally, and we have a stem cell trial where we're using stem cells periadventitially first in human. So I think there's advantages. One is periadventitial targeting versus endoluminal. I would submit to you first pass effect and total amount of drug that can be delivered. And then some of the other challenges, repeat administration. What's the easiest way to do repeat administration? And then, you know, the timing of it would be the other things to think about. I will say, I think there are differences. I don't have the data in front of me. We have a tissue biopsy where we sample the endothelium from cephalic arches and the anastomosis. And the question that I think that remains is, you know, which drug is the best drug for that patient at the time of intervention? And then lesion-specific characteristics. If you look at the coronary data with washout of drug, will the drug wash out faster at the juxta-anastomosis because of the higher flows and abnormal shear than maybe a cephalic arch? So I think there are lesion-specific characteristics that we'll eventually, I hope, move to understanding. I'm not convinced that every lesion can be treated the same, whether it's a single drug, the same amount of application, the same amount of drug, et cetera. So I think we'll hopefully move this field into that direction.
Thank you, Dr. Misra. So you raised two very important points earlier on. One on the biological differences in different parts of the circuit, and two, differences in population between Asian population and also Western population. I think time is moving on. I'd quite like to discuss those 2 points later, but can we just maybe go with your presentation first? I think it's fantastic that Concept Medical are funding all these clinical programs, including the Impression RCT and also the US FDA study on the Magic Touch AVF. So please, Dr. Misra, to your presentation, please.
Hi, thank you for the invitation to speak at length. I'm going to speak about the Magic Touch arteriovenous fistula study and the current study design. My name is Sanjay Mishra and I'm from the Mayo Clinic in Rochester, Minnesota. These are my disclosures. Study design. So this will be a prospective, global, multi-center, single-blinded, one-to-one randomized trial. And really the objectives are to evaluate the Magic Touch AVF, which is a sirolimus-coated balloon, versus standard PTA for the treatment of de novo or non-stenotic or non-stented restenotic lesions in the AV fistulas. And these lesions can be up to 100 millimeters in length. So this is what the Magic Touch balloon looks like. This is a sirolimus-coated balloon that was designed by Nanolute Technology. And the drug is in a submicron particle and it's carried with a phospholipid carrier that allows it to be delivered to the vessel wall. And so our study design is, again, one-to-one randomization of de novo or restenotic lesions that can be 100 millimeters or shorter in length in the arteriovenous circuit. There will be 376 patients that will be randomized. And again, this is a global study. And so this will be divided between the US, Asia, and Europe. So what are the inclusion criteria? I've really highlighted the most important ones. Number one, this has to be a mature AV fistula, which is defined by a fistula that's been created more than 60 days prior to the index procedure and also undergone successful dialysis for 1 month. The lesions can be anywhere from the anastomosis and up to 2 centimeters on the arterial side to the cephalic vein in 2 centimeters into the subclavian vein. The target lesion has to be less than 100 millimeters in length. And there can be tandem lesions, but they have to be separated by a gap of 3 centimeters. And the target lesion diameters are 4 to 12 millimeters. And this is after patients are randomized after successful angioplasty, which is defined as residual stenosis of less than 30% or absence of flow limiting dissection. What are the exclusion criteria? I've highlighted the most important ones. Presence of central venous stenosis with more than 30% residual angioplasty, residual stenosis after angioplasty, patients who have undergone a stent placement, patients who may get a kidney transplant within 6 months, or patients who may get converted to peritoneal dialysis. So what are the primary endpoints? The primary endpoint is the safety and efficacy of the sirolimus-coated balloon compared to standard angioplasty. The primary endpoint is target lesion primary patency at 6 months, and the safety endpoint is serious adverse event rate within 30 days. So the primary outcomes will be target lesion primary patency rate at 6 months, and this is reached if the patient has a repeat intervention that's clinically driven, and also has an angiogram that shows more than a 50% recurrence of stenosis. And the clinically indicated indications are described below. They can be one based on physical exam, and these are standard definitions: ipsilateral edema, changes in the pulse, changes in the thrill, changes in the bruit, failure of the fistula to collapse when the arm is elevated, or excessive collapse of the venous segment upon the arm elevation. Also, they can be driven by dialysis. What happens at dialysis? Difficulty in cannulation, aspiration of clots, inability to achieve target dialysis blood flow, prolonged bleeding, and changes in KT over V or recirculation times. The secondary endpoints are described there, and they will be censored at these different time points: access circuit primary patency, target lesion primary patency, cumulative target primary revascularization, number of interventions, and the number of interventions required to maintain access circuit patency and target lesion patency. Then we will do ultrasound at different time points, again at 3, 6, 12, 18, and 24 months. I want to thank the organizers for this opportunity to allow me to speak to you. Have a good day.
Thank you, Dr. Misra. Your first point regarding the biological activity of the intimal hyperplasia, as far as I understand, the reason for the recurrence of stenosis for AVFs are smooth muscle cell proliferation, inflammatory activity leading to the intimal hyperplasia. So this is where I believe sirolimus comes in as potentially advantageous. Sirolimus has, in addition to its properties in inhibiting the proliferation of smooth muscle cells, it can also inhibit the migration of smooth muscle cells. And secondly, it has anti-inflammatory properties, immunosuppressive properties as well. So this is where I believe sirolimus has got advantages over Paclitaxel. And perhaps I could also ask you, you run animal studies. So in your opinion, what are the key histopathological or the pathological processes underlying the recurrence of stenosis for the AVFs?
Yeah, so I think that's a very excellent question. The model that Alok described, my lab initially published on, which was a pig model, iliac artery to iliac vein fistula. What we now use for PTA AV fistula stenosis is a murine model. And there's a couple critical components. One is uremic condition, so we create kidney failure. 2 is when we angioplasty in the mouse, it's a stenosis that's formed. And so, and then 3, we do this with direct visualization of the vein. So if you use that model and look at histologic specimens from humans, there are some salient features. One of them is inflammation, as you just alluded to, the presence of macrophages, and then also transdifferentiation of smooth muscle cells, and finally proliferation. And the other component is going to be matrix deposition. Remember, high pressure balloons were created for AV fistulas. We never used high pressure balloons in the arterial system until the high pressure balloons were started to be used by Bard, for example. So I would say the components are proliferation, migration, collagen matrix, and then finally, obviously, a high amount of inflammation. And the last point I'll make for this audience that we take for granted is when arterial studies are done, All the patients that are enrolled do not have kidney failure. I'll say it one more time. Patients with kidney failures are excluded. And so we've got a opportunity here with uremia and CKD that's pro-inflammatory beyond what we would see in the arterial beds, coronary beds, arterial disease, et cetera. So those are, I think, the biggest points I'll make.
Thank you, Dr. Mishra. Just quickly before we close this session, we're back on track now. I've got a question from the audience. Eddie, maybe I put this to you. What about the use of scaffolds in AVFs? Obviously, that will potentially deal with your recoil. What about loading the drug onto that scaffold? What about use of drug-eluting stents in the AVF setting?
Okay, so really the use of scaffolds are limited to, in my practice, to areas like the cephalic arch, and also for AVGs in between the vein graft junction, and also in conditions where you've accidentally ruptured the AVF and you can't control it with prolonged balloon tamponade, then you need to use a covered stent then to bail yourself out. But apart from that, I think my practice is to try and limit putting in any permanent implant in the patient, and if I can help it, I would prefer the use of drug-coated balloons over scaffolds.
Thank you very much. So I'd like to conclude this session by just summarizing what we've found. Sirolimus is a very promising use of drug for the AVF setting. The data is still very preliminary. I don't think you can really make a comparison yet with Paclitaxel. There are ongoing randomized controlled trials using different balloons in the AVF setting, and we look forward to that. I think the biochemistry of use of the molecular mechanism of sirolimus has its potential advantages over Paclitaxel, but how that's going to play out, we still need a lot more data. I want to thank the panel and my co-moderator, Dr. Choke, and I close this session. Thank you very much for listening. Have a good day.
Thank you.